I am Dr. Jayakumar, working at Aster Medicity, Cochin. Today we are going to discuss about diabetes associated with pregnancy. If you look at a patient who is pregnant and diabetic, it can be due to three possibilities. One is that she has been perfectly normal before pregnancy and she developed glucose intolerance, or a diagnosis of diabetes was made during pregnancy, and after delivery, 6 weeks after delivery, she is going to be normal perfectly. So that is the one person having glucose abnormality or diabetes only during pregnancy, which completely clears after 6 weeks after delivery. That group is called gestational diabetes mellitus, one of the types of diabetes mellitus in the classification, gestational diabetes. The other group is pre-gestational diabetes, that is a non-diabetic patient, type 1 or type 2, having diabetes for many years, want to become pregnant and becoming pregnant. That is a second group. And the third group is a person who has been perfectly normal but may be having some risk factors for developing diabetes. During pregnancy gets diabetes, but after pregnancy it does not revert back to normal. In other ways, she has got type 2 diabetes during pregnancy. That is the one. So these are the three group of people. Now if you look at the aspects of diabetes and pregnancy, let us start with the second group, that is a non-patient of type 1 or type 2 diabetes who became pregnant or wants to become pregnant. So it is a must that this group of patients must be properly educated about the need for a very tight control before they plan for pregnancy. This is because during pregnancy, the first 8 weeks, during 7 to 8 weeks, is the time when organogenesis, all the organs in the body is being developing. And if the metabolic milieu is not normal at that period, there can be defect in organogenesis with congenital malformations and congenital abnormalities occurring in this phase, and some of them will end up with abortions at this time. So already known diabetic patient, type 1 or type 2, must plan for a very tight control and before they plan to become pregnant. Second thing is, when they want to become pregnant, type 2 diabetes on OHAs, they must be willing to stop all the drugs except metformin and go for tight control with the use of multiple dose of insulin, and then only they can become. The third condition is that, so first is good control, second is omitting oral hypoglycemic drugs and all those things and controlling diabetes with insulin and before planning pregnancy, and third thing is assessment of the complications, existing complications level before pregnancy, so that a proper advice can be given and proper prediction can be made of the future diabetes status after pregnancy. See, as you know, in type 1 diabetes may be having for many years before they planning for pregnancy, and so they can have renal nephropathy, they can have retinopathy. So all these complications must be properly assessed once you are planning for pregnancy. For example, the patient's urine albumin creatinine ratio must be properly monitored, renal function must be properly monitored, her fundus examination must be properly done with the dilated under the supervision of an ophthalmologist, and make sure that there is no retinopathy, or if it is present, what is the state of nephropathy, what are the stage of is a proliferative one or pre-proliferative one or a proliferative retinopathy. So these all must be sorted out. This is important because pregnancy is a stressful situation and it will add strain to the existing diabetic patients, and some of the complications can get worsened during the course of pregnancy. For example, retinopathy is known to get worsened during pregnancy. Similarly, nephropathy can also get worsened during pregnancy. So these must be properly discussed with the patient and proper action taken, and they are properly educated so that they are willing to take up that responsibility or the risk of having little worsening of some of these complications once they want to become pregnant. So this must be the second one, it must be properly controlled. And third thing is that the patient must be willing to do periodic or more frequent monitoring of blood sugars during pregnancy, not like the pre-pregnant state. Here every day the patient has to check the fasting on the 3 postprandial blood sugars to make sure that the best control is available for that patient concerned. So this is type 2 pre-existing diabetic patient must be properly educated, properly controlled, and properly educated regarding the pregnancy related outcomes as far as the diabetes is concerned. Then for that gestational diabetic patient, usually gestational diabetic patients, there is no agreement on the time of screening or the type of screening to find out whether somebody is having gestational diabetes, because usually people say universal screening. In India, many of the gynecologists and many of the diabetologists advise universal screening, but in Western countries, some countries they advise only screening people with high risk and all those things. But being a nation itself is a high risk, so I think we in India, it is a must that all the patients must be screened for gestational diabetes, being in India. And the time of screening is usually the second step after 28th week, but if you have got a high risk patient, strong family history, previous history of glucose intolerance and all those things, you must start screening even the first trimester itself to see what is happening. The screening criteria, there are different types of screening for gestational diabetes. One is called 2-step screening. One is a screening, one is a confirmation. That is, the moment the patient comes to the hospital, the antenatal clinic, she is given a lot of glucose, what time, whether it need not be fasting any time of the day, and in 1 hour random blood sugar is checked after taking the glucose load. 75 gram glucose given, and 1 hour later blood sugar is checked. If it is more than 140 milligram 1 hour, the patient is most probably having gestational diabetes and has to undergo a glucose tolerance test to confirm that it is. If the patient is having less than 140 milligram percentage, this 1 hour value in the screening test after a glucose load, then the patient can be assured that at present she is not having gestational diabetes. You can do it later on in the period of the pregnancy. And once they make a diagnosis of screening test, there is a suspicion with a more than 140, the next question is you have to confirm it by doing a GTT. There is a lot of confusion. There are, WHO says the usual standard 75 gram 2 hour GTT, whereas American Diabetic Association says 100 gram 3 hour GTT. Then there is another association called HAPA which advise also 2 hour GTT with 75 gram but only 1 abnormal value, whereas ADA says that 2 abnormal values to make a diagnosis. So I'll say that for the ordinary WHO GTT, you give 75 gram glucose and do a 1 hour and 2 hour value. If the 2 hour value is more than 140, you can make a diagnosis of gestational diabetes. That is usually 140, more than 140 in an ordinary GTT in a non-pregnant lady will be equivalent to pre-diabetes. Here that is taken as diabetes by WHO. Then if it is a HAPO criteria, HAPO agency's criteria, you do a 75 gram glucose, fasting sugar more than 92 milligram, or 1 hour value more than 180 milligram, or 2 hour value more than 153 milligram. If any one of these values is abnormal, then the patient is having gestational diabetes. Then lastly, we can look at the American Diabetic Association criteria. Here they advise 100 gram glucose tolerance test, and 4 values are taken, that is 3 hour fasting and 3 hours. The fasting more than 95, 1 hour more than 180, 2 hour more than 155, and 3rd hour more than 140. If 2 of the these 4 values, any 2 are abnormal, then the patient is having gestational diabetes. So you can follow, now there will be confusion, which one should I follow? I think you have to make your own decision in your clinic, what is the one which is very convenient for you, convenient for the patient. You select one and stick on to it. That is what my suggestion is. Now, having made a diagnosis of gestational diabetes or already existing diabetes, then now the question arises of management. So in the management of diabetes in a pregnant lady is very simple, but it takes a lot of cooperation from the patient and the laboratories. The patient must be willing to have a glucose meter at home to monitor the blood sugar frequently. If she can't afford to buy one, we can even rent one for during the period of pregnancy to find out one, to monitor this one. And which one to monitor, there is again confusion. The blood sugar monitoring must be done at fasting level and at 1 hour after breakfast, after lunch and after dinner, or 2 hour. So whether you must follow 1 hour value or 2 hour value, it left to you, but many other associations advise for 1 hour fasting and 1 hour post breakfast, post lunch and post dinner values. And the criteria taken is that 1 hour the fasting must be less than 95, and the target the 1 hour target must be less than 140, 2 hour targets must be less than 120, and the other thing is you have to do hemoglobin A1C estimation, which must be less than 6%. Now every day you will have to do these 4 values, and usually hemoglobin A1C is done once in 3 months in a routine practice. But here the pregnancy period, diabetes, gestational diabetes may last only for about 10 to 12, 14 weeks. So there is not much enough time to do every 3 months. So better to do it every 4 to 6 weeks time. So because the rapid turnover of glucose is there, and the pregnancy is a rapidly changing metabolic milieu, and hemoglobin A1C gives the last 4 weeks value better than the rest of the values. So I think it is the advice is to do once in 4 to 6 is hemoglobin A1C, and the target is to keep it below 6% for the very good ideal outcome. Now coming to the management, just like managing diabetes in a non-pregnant lady, management diabetes includes lifestyle changes and medications. Lifestyle changes is the dietary restriction, but it is not the ideal time. You may say that the pregnancy is for a short period, the lady will have different tastes, sensations during the pregnancy period, and why do you want to be so strict, and the patient is going to be given medicines, why are you going to be very strict with it? That is one aspect is correct, but you can give some broad advice like that the carb content of the meals can be reduced. The patient can eat likings, but the carbohydrate content can be reduced to the minimum as much as she can. Then that is about the diet, and frequency of the meals in between snacks will be better rather than having 3 major meals. So in between snacks, because in a pregnant lady the fetus will be drawing the glucose very fast after the meal, and there can be after 2 hours it is a first value is the postprandial hyperglycemia is the most important thing in diabetes in pregnancy rather than the fasting abnormalities. So the diet should be less in carbohydrate, less in sweets, and the carbohydrate content must be reduced as much as possible, and small snack in between feed snacks can be given. Then coming to the exercise, it's not the ideal time to start an exercise in a diabetic patient, but some form of physical activity or some form of walking must be encouraged rather than lying in the bed round the clock being pregnant. Third thing is about medications. So as I have been said that the medications of managing diabetes in pregnancy is only by insulin therapy. Maximum you can continue with metformin therapy if it is the patient is already on metformin for PCOD, becoming pregnant. There is no contraindication to continue that, but otherwise for the first time diagnosing pregnancy, the treatment is lifestyle changes followed by insulin therapy. Now the lifestyle changes, how long you wait. In a normal non-pregnant lady, if somebody is becoming diabetic, you may advise the patient is obese and all those things. You will advise lifestyle changes and review the patient after 4 to 6 weeks and make sure whether to go for pharmacotherapy or not. But here the pregnancy is for a short period, there is not enough time to give so much time for lifestyle changes. So usually I advise a person to be once the diagnosis of GDM is made, ask them to follow whatever dietary restrictions and whatever exercise is possible, and within a week or two you must make up your mind whether the patient is under good control, whether you should go for pharmacotherapy or not. So maximum 1 to 2 weeks time, if it is you give to see the effect of lifestyle changes in the glucose turnover. And after within a week or two, if you are not able to achieve the target of 95 fasting and 140 1 hour ppbs, then you have to consider giving insulin therapy. As has been already said, it is the postprandial hyperglycemia is the main culprit in pregnancy related diabetes. So the main theme of treatment is giving short acting insulin before meals. Usually nowadays we have got insulin, short acting insulin analogs are available, which has got a fast action and which will control the postprandial 1 hour value much better than the standard existing human insulins, so regular insulins. So analogs are ideal. You can start with 4 units or 4 to 6 units depending upon the blood sugar values, and it asks the patient to monitor all these values, 1 hour values, and you can go on every other day. You can step up the insulin dose by 1 to 2 units depending upon the blood sugar values if you are able to. And so the aim is to keep 1 hour post meal values around 140. You titrate the short acting insulin analogs. Then look at the fasting value. If the fasting value is more than 95 and you are not able to achieve it, is not getting control with the lifestyle changes and short acting insulin, you may have to add on a long acting insulin. And the long acting insulin usually added is NPH insulin, is usually added at bedtime. Then the patient, suppose the patient is already on a long acting insulin analog like Glargine, you can continue that. There is no harm in continuing it. But for the first time starting in a gestational diabetes, if you want to add a controlled fasting hyperglycemia, it is the NPH is usually taken as the insulin of choice for it. Then you can manage, you adjust the dose of the NPH insulin or Glargine insulin at night to keep the fasting less than 95. So these are the two things which are possible. For the type 2 diabetic patients or type 1 patients, you had to continue with their previous regime, and usually they all require basal bolus therapy to control it. And a type 1 diabetic patient who has been on multiple doses of insulin, not getting control properly during pregnancy and had previous bad obstetric history, is an ideal candidate for insulin pump therapy, especially if the previous obstetric history is very poor, and one of the reasons for the poor obstetric history is due to fluctuating or little uncontrolled diabetes state. Then that patient is the ideal one for using insulin pump therapy, so that you get a very tight control and the chance of avoiding, and you will be able to avoid the obstetric complications of this. So we have done that in the past, giving pump for the first time in pregnancy for getting a tight control and getting the good obstetric outcomes in that patient. So with all these things, I think you will, the gynecologist will be monitoring the growth of the fetus and the volume, the head, look at the amniotic fluid volume and all, seeing the patient's other health parameters. And if everything goes on well and you tightly control the patient can go in for the normal labor or the expected time. And during the labor, make sure that the insulin, the blood sugar monitoring is done very hourly and the dose of insulin adjusted. And some of them may require small continuous insulin infusion during the delivery time. All patients with gestational diabetes, once the delivery is over, they may not require insulin, and because the moment the placenta and all the anti-insulin hormone sources are out of the body, the blood sugar dips down, and they may not require further insulin, or even they can may not require even other drugs which for controlling the blood sugar at that time. And make sure that all the diabetic patients, especially a diagnosis of gestational diabetes has been made, must undergo a GTT at 6 weeks after delivery to make sure that it is only gestational diabetes and not a type 2 diabetes which has appeared for the first time in pregnancy and continuing. So with that, I think the management of pregnancy related diabetes extends up to 6 weeks after delivery till you can be able to confirm that it is a case of gestational diabetes or not. So I think with this we will be able to get a good management for pregnancy diabetes, and the outcome will be very good. Thank you very much.